Okay, the next 30 minutes, I'll try to cover something which is interesting and possibly boring for most presidents, I suppose. Interesting for some people, but boring for most people. So before I start, let's start something with introduction to a book. I don't know how many of you have seen this book. How many of you raise your hands? So this is actually 50 studies everyone should know. There's a series of books in which recently launched 50 studies every neonatologist should know. Okay? And it is edited by Roger Saul, who is the Cochrane neonatal editor, and Harish Kriplani, who is the author of many trials, including the top trial, and one of the most brilliant neonatologists I have ever known. Now, this book lists many studies, of course, 50 studies, obviously, and I have just listed some of the studies: beta ROP, caffeine for apnea of prematurity, PREMOT, PNET, which is for erythropoietin, ProPrems probiotics, resuscitation air, room air, SAIL study, sustained inflation study, support, which is for CPAP and for lower oxygen saturation, top for transfusion of preterm units, and so on and so forth. What I would like to highlight is no studies by Indian researchers. Of course, Indians who have migrated to US, there are some studies, but no studies from India as such. Okay, of course, if you exclude WHO, IKMC, and something else, but there are no studies by Indian researchers. Now, I looked at another group of studies. This is the NICHD, National Institute of Child Health and Development. Then they have a network, Neonatal Research Network, NRN. And of course, this is US, so this is the NRN studies. So obviously, there will not be any studies from India, but just want to highlight. So this is you have the years and then the studies published by NRN. If you look at the studies, so the PPHS study, stop ROP, that is ROP which based on which our treatment guidelines are based. TIP, which is for indomethacin for prophylaxis of preterm infants, we are no longer using, but based on which the PDA management sort of revolutionized. Ballard's whole body cooling, delayed cord clamping, surfactant, support trial, ALPS trial, hydrocortisone for BPD, and so on and so forth. Essentially, almost all pioneering studies are from high income countries. I'm not trying to discourage or discredit the low middle income countries or Indian researchers. I'm trying to put it in a way that it's time we just pull up our socks. We are not doing till now that we are not able to figure in 50 studies every neonatologist should know, not even one study from us. So why? I'll try to answer this question. I don't know how many of you know him. No one? Abhay Bang. So this is Abhay Bang. So I attended one of the talks about a few years ago, exactly in this means in Chennai. So he said, research is not research. Think about it. We almost always end up doing researching. We are not doing research. There's no innovation. There's no contextualization. We just copy and we just copy paste. That's it. That's not the way research should be done. It's time we have our own network and we try to answer our own questions. And not necessarily that we need recognition from the West, but we need to answer the questions which we need to answer by doing studies based on Indian neonates, and then we try to answer. And then, of course, we should be pioneering some studies which even the high-income countries adapt. I think that's the setting. With that, I will try to jump into the topic. Typically, when you talk about anybody who talks about this topic, landmark studies, pioneering research, what they will do is they'll start with studies on perinatology and resuscitation, respiration, sepsis, brain, development, heart, nutrition, and go on and go on and go on. And they will study system-wise, they will list all the studies. And that will be the most boring. Yeah? 12 o'clock, 12:30, pre-lunch or post-lunch, to list all the studies, named studies or unnamed studies, and then just this is the study, this is the study, this is the study. We can actually switch off the light for the next half an hour. We can sleep. You can also sleep. I can also sleep. There's no way we can be awake by the end of this half an hour. So what I will try to do is I'll try to make it interesting by giving some case scenarios. I'll ask you to identify the optimal management strategy and what is the evidence for that, and if there are any recommendations. So that's the format which I will follow, and with that, I'll try to make it interactive. And of course, it's not possible to cover all pioneering studies. It's not possible in 30 minutes. So I've just highlighted which I thought are important. And of course, there are studies that I have not covered, but that does not mean that they are not important. So the first case, so the preterm 30-weeker, 1150 grams, born to a primary mother who had gestational diabetes, born by emergency LSCS, and the baby cried at birth. So you're attending the delivery, you're receiving the baby cried. So what will you do? Options are immediate cord clamping, delayed cord clamping, umbilical cord milking. Option A, raise your hands. No. Option B. Okay. 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 So let us look at the evidence. So delayed cord clamping, this is one of the largest studies on delayed cord clamping in preterm neonates. This is an Australian placental transfusion APTS study published in NEGM. And they randomized about 6,000 newborns, 800 each, to immediate cord clamping and delayed cord clamping. Immediate cord clamping is within 10 seconds of the delivery, and delayed cord clamping is 60 seconds or after. What they found was interesting. So the outcome was death or major morbidity by 36 weeks of postmenstrual age. And first we'll look at the last part. So this is something like a forest plot of a systematic review. They have used that type of figure to summarize the results. So essentially how to interpret is if this diamond is crossing this vertical line, there's a line of no difference. That means relative risk of 1 is a line of no difference for relative risk. So if this diamond touches 1, that means there's no significant difference. So essentially there's no difference between immediate cord clamping and delayed cord clamping. If we don't have to look at the subgroups, whether it's male or female, gestation less than 27 weeks, broadly there's no difference. That's APTS study. Now we'll move on to the study on delayed cord clamping versus cord milking. And this is a study by Anup Kateria, published in JAMA, umbilical cord milking versus delayed cord clamping. Okay, the previous one was delayed versus immediate. This is milking versus DCC. And they enrolled 474 infants, and of which this is a subgroup gestation of 23 to 27 weeks and 28 to 31 weeks. This is important because we'll come to that in the subsequent slides. Now, if we look at the outcome, this is a primary outcome, that is death or IVH. We'll come to that. But overall, death or severe intraventricular hemorrhage, if you look at the overall study population, 12% risk of death or IVH, severe IVH, in the umbilical cord milking group, and 8% in the delayed cord group. P-value is 0.16, so risk difference is also crossing 95% CA of risk difference is crossing 0, therefore there is no difference. Now if you look at individual outcome, there is a composite outcome of death or IVH. Now if you look at only IVH, there's a significant difference with the IVH incidence being much higher in the milking group than in the delayed cord clamping group. So that's 8% severe IVH in the umbilical cord milking group and 3% in the delayed cord clamping group. And the risk difference is 5%, and the confidence interval is 1 to 9%, and the p-value is 0.02. And if you look at the subgroup analysis, this difference is essentially because of 23 to 27 weeks, the LGANs. So 22%, so 6%, so there is a 16% increase, absolute increase in the risk of severe intraventricular hemorrhage if you do umbilical cord milking versus delayed cord clamping. So what's the final conclusion? So this one study, which I showed that DCC versus ECC, the immediate cord clamping, there's no difference. And the other study I said, umbilical cord milking possibly is more harmful, particularly in LGANs. Now, I try to avoid talking about systematic reviews, but in this case, because there was some confusion, so I just took this help of this ICOMP systematic reviews published in Lancet. So this is delayed cord clamping versus immediate cord clamping. If you look at the overall pooled effect, this includes, of course, the largest study is the Australian study, which I mentioned. And of course, there are many other studies. We will not go into that. Many of them are small studies, and some of them did not actually even have events. So this is the outcome is death. This diamond is not touching the line of no difference, and therefore there is a significant effect. Okay. And if you look at the pooled effect, it's 0.68. That means 32% reduction in deaths with delayed cord clamping compared to immediate cord clamping. Okay. And that's why we use delayed cord clamping even in preterm neonates. So that is 32% reduction in deaths if you use delayed cord clamping when in comparison to immediate cord clamping. So what about umbilical cord milking? Now this is umbilical cord milking versus immediate cord clamping. Here, if you look at the pooled effect size, this is touching 1, so there's no significant difference, and that's reflected in the 95% CI. So cord milking versus immediate cord clamp, there's no significant reduction in deaths. And therefore, the NeoCORE recommendations are actually, it came before that, but based on the systematic reviews done before that. So for preterm infants who do not require resuscitation birth, delay cord clamping for longer than 30 seconds. Okay, that's what the NeoCORE recommendations are. So you're right, most of you raise your hands for delayed cord clamping. So delayed cord clamping is to be done for preterm neonates. So if preterm neonate, vigorous at birth, delayed cord clamping. Now move on to the next question. So 30-week, 1150 grams. This baby cried at birth. Delayed cord clamping was done. The baby was shifted to NICU. The baby is on CPAP of 5 centimeter and 25% FiO2. When will you initiate KMC? Shankar or skin-to-skin contact. So options are, once hemodynamically stable, after weaning off from CPAP, after 72 hours of age, after removing the umbilical lines. Option A, raise your hands. Good. Option B, after C, no. D, okay. Anyway, the right answer is not there here anyway. The immediate KMC is skin-to-skin contact of infants started immediately after birth, even before stabilization. Okay, so there is immediate concurrent mother care. So if the baby is really sick, requiring inotropes, intubated, required intubation at birth, severe asphyxia, those are the babies who are excluded from the WHO KMC study, but all other babies between 1 and 1.8 kg, they were all enrolled. So even before stabilization, that's what we are looking at, immediate concurrent mother care. So this is a study published in NEGM, WHO KMC study. And if you look at the median time to initiation of KMC in the intervention group, so they enrolled 1,600 babies in intervention group and 1,600 babies, odd babies in the control group. The median time to initiation of skin-to-skin contact in the intervention group, that is immediate KMC group, was 1.3 hours. And the interquartile range is 0.8 to 2.7. So within 3-4 hours, most babies, more than 75% of the babies, actually were put on skin-to-skin contact. And the control group, that's typically what we do, the third day, 53.6, and the interquartile range being from 33 to 100 hours. And if you look at about 2/3 of the babies, initiation of KMC was done within 2 hours. Now what it showed, immediate KMC, if you look at the outcomes, the primary outcome is death. Between enrollment and 20 days, there is basically neonatal mortality. There is 12% risk of death in the intervention group and 15.7% risk incidence in the control group. The risk ratio is 0.75 and the confidence interval does not reach 1. So therefore, the p-value is significant. In other words, RR of 0.75 means the mortality is reduced by 25%. So there is 25% reduction in mortality if you initiate kangaroo mother care or skin-to-skin contact immediately after birth. And therefore, the WHO recommends kangaroo mother care for preterm or low birth weight infants should be started as soon as possible after birth. So that's the recommendation. Of course, most of us are not doing, but because of feasibility considerations. But the recommendation is to start KMC immediately after birth. There are problems with and there are genuine concerns. But of course, we're not going. We're just looking at the studies that have sort of changed the practice. And the government of India also has come up with a guideline to start mother and newborn ICU for immediate kangaroo mother care. And they have also given some standard recommendations, what all should be this thing for mother and newborn, requirements of mother and newborn ICU. Now, moving on to scenario 3, the 33 weeks, 1675 grams, born to elderly primary mother with gestational hypertension, emergency LSCS, the baby did not cry at birth. What will you do next? So you're in the delivery room, you have received the baby is born limp and cyanosed. So the options are immediate cord clamping, delayed cord clamping, umbilical cord milking, and the first three, first you do this and then do resuscitation. And the fourth, start resuscitation, TPV, and then clamp the cord, resuscitation with intact cord. So option A, raise your hands. B, C, D. Oh, good. Okay, so now we'll look at neonatal resuscitation with intact cord. So this is went first study, published in JAMA Network Open. They enrolled babies of 23 to 28 weeks. So extreme preterm, it's like 28 weeks also. So extreme, I think 28 also, yeah. So 23 to 28 weeks, 570 neonates, 278 neonates to ventilate first. That means first ventilation followed by cord clamping up to 120 seconds. So ventilation first and then cord clamping. And the control group or the usual group, clamping by 30 to 60 seconds and then starting ventilation. Okay, that's what normally we do. Now, if you look at the findings, these are the outcomes, the IVH or death. Death or IVH is the outcome. So this I mentioned. So the death or IVH, there is no difference. Went first, whether you start ventilation or not, there's 35% risk of death or IVH, and the control group 32.5. And if you look at the relative risk is 1.02, there is no difference. So neonatal resuscitation with intact cord versus delayed cord, because this is 30 to 60 seconds with a delayed cord clamping, no difference in death or IVH. Next is PCS trial. This is intact cord resuscitation compared with umbilical cord milking. They enrolled 212 newborns, again 23 to 29 weeks, roughly you can say extreme preterm. 104 to umbilical cord milking, half to the remaining to resuscitation with intact placental circulation, intact cord. The composite outcome was death, IVH or BPD. So the previous one, death or IVH, here death, IVH or BPD. If you look at the numbers, it's roughly about 35% in the cord, intact cord resuscitation, and about 38% in the other group, cord milking group. Again, there is no difference in death or IVH or BPD, the composite outcome, between milking and neonatal resuscitation with intact cord in extreme preterms. Now, what about term neonates? This is MINV study, MINV, I suppose. This is umbilical cord milking in non-vigorous infants, a randomized crossover trial, again by Anup Kateria. So this is a cluster randomized trial. So the hospitals were randomized. So if the baby is born between 35 and 42 weeks of gestation, non-vigorous at birth at 15 seconds, then they randomize by center to umbilical cord milking or early cord clamping. But even though they call this as the early cord clamping, but the cord clamp was done within 30 to 60 seconds. So sort of delayed cord clamping and then resuscitation. So the difference is clamp first and then resuscitation in the early cord clamping group. First milking and then resuscitation. So in that group. So what they found was in these neonates, umbilical cord milking versus early cord clamping, there is no, the primary outcome was NeoCORE admission, there is no difference. But what they found was therapeutic hypothermia, the need for therapeutic hypothermia was reduced in babies who had underwent umbilical cord milking. Apgar scores were slightly better, but other not very different. So possibly they conclude that possibly it is beneficial. And this is a study from India, and there are many studies I think being currently conducted or being published. So this study from Chandigarh, Dr. Chawla et al. So they found the better physiological parameters with intact cord resuscitation when compared to early cord clamping. So in India, it seems it's safe, it's feasible, but possibly beneficial. We do not have the long-term outcomes. So the LCAR does not recommend right now, does not recommend the intact cord resuscitation. So this, for term and preterm infants who recur resuscitation birth, there is insufficient evidence to recommend early cord clamping versus early cord clamping. That's what, and it does not talk about the cord resuscitation. But possibly, the next guideline, by that time, if you have enough evidence, we might change our practice to resuscitation with intact cord, because possibly there's no harm, definitely, and physiological parameters becoming stable. And then if you have other studies that showed long-term benefits, two-year outcomes more better, in that case, we might change the practice. But right now, it's equivocal. Now we're moving on to the third scenario. 38 weeks, 3.1 kg, born to a primary mother, forceps delivery, born limp and cyanosed. Required PPV and chest compressions, Apgars at 5 minutes 2 and 10 minutes 4. Baby was found to have altered sensorium at 2 hours of life. Will you start therapeutic hypothermia? Yes? Yes, how many? No? No. I think you need lunch? Yes, no? There are only two options. Yes and no? Okay, equal. Surprising. Okay, so this is the study, which is like a helix study. Most of you must have heard. So the hypothermia for moderate or neonatal encephalopathy, what they found was interesting. So this is hypothermia, 200 babies and until 200 babies. Death or disability, there is no difference. Okay, but what they found that if you segregate it, only deaths is higher in babies who actually received therapeutic hypothermia. So it's 42% risk of death in babies who actually were exposed to therapeutic hypothermia versus 31% in the control group. The risk ratio, the relative risk is 1.35. That means 35% increase in the risk of death in babies who underwent therapeutic hypothermia. And the p-value is 0.002 because, and the confidence interval, you can see this, it's not crossing 1. And what they concluded is interesting. Therapeutic hypothermia should not be offered as a treatment for neonatal encephalopathy in low and middle income countries. That's what they concluded, which is a very strong statement for a study which is possibly did not deserve such strong conclusions. There are many letters to editor, but the NNF came up with its own position statement because it was very controversial. So I think Dr. Nisha and others were part of this group, and Dr. Vishnu Bhatt was published, and from CMC, they have published a lot of studies on this. So this is a position statement by NNF. So what it says is, if the pH is, so if the baby is more than 36 weeks, more than or equal to 36 weeks, less than 6 hours, pH is less than 7, base X is more than base excess or base deficit of 16 or more, Apgar scores of less than 5, history of acute perinatal event, and that's something which they have added possibly as a sort of to balance it out. So this is a must criteria because it's and history of acute perinatal event which they have defined, and then evidence of moderate encephalopathy. So if this baby, the baby which I showed had any history of this thing, that baby qualifies for therapeutic hypothermia. The baby has to undergo therapeutic hypothermia. So the issue is not to give therapeutic hypothermia, but to make sure that you monitor the baby properly and you pick up complications early and you treat properly. Without that, the only treatment which is possible proven to be beneficial in asphyxiated babies, we will lose that as well. So make sure that you monitor the baby, pick up complications early, and then treat properly. Now moving on to the sixth scenario, 27 weeks, 990 grams. The baby received intubated at birth, rescue surfactant, 64 hours of life, the baby is on CPAP, 6 centimeters of water, and 30% FiO2. ECHO shows PDA size of 1.6 millimeters and an LAIO ratio of 1.5. What will you do next? The options are wait and watch, fluid restriction and diuretics, treat with IV paracetamol, treat with IV brufen, or I don't know, IV brufen is easily available, not oral brufen. Option A, okay. Option B, C, okay. D, okay. So this mixed bag, we'll come to that, okay. So PDA to treat or not. So this is the Benedictus trial, expected management or early brufen for patent ductus arteriosus. What they did was they randomized 273 infants who were born before 8 weeks of gestation with echo confirmed ductus, that is more than 1.5 millimeter in diameter, and left to right shunt. They assigned them to expected management or ibuprofen up to 3 courses, and roughly 136 babies in both groups. The primary outcome was a composite outcome of death, NEC, BPD. Okay, death or NEC or BPD. What they found was the expectant group, means conservative management group, not treated. The risk of death or BPD or NEC was much lower. It's only 46.3%. Whereas in these babies who were treated with the brufen, it was 63.5%. So the difference is minus 17.2. So you can see the absolute difference is minus 17.2 and the upper bound is minus 1. So this was actually non-inferior trial. They proved that expectant management or conservative management is not inferior. Actually, it is superior to treatment with ibuprofen. So they concluded that in extremely preterm infants with ductus, expectant management was non-inferior to early brufen if you take a composite outcome of BPD or death or IVA or NEC. Now the next trial is Baby Oscar. Trial of selective early treatment of PDA with ibuprofen. So what they did, again, this is done in UK. They randomized babies with large PDA, more than 1.5, born between 23 and 28 weeks. They randomized, this is a much larger study, 653 infants. Brufen is a typical dose versus placebo, okay? And what did they find? So the outcome is death or BPD. Again, you can see there is 69.2 in the brufen group and 63.5, and the relative risk is 1.09. There's no difference. If at all, slightly, actually, of course, there's no difference. You can see the p-values. But the 95% CA, the lower CA is closer to 1 on one side. So it's possibly, if at all, there is possibly some harm. Definitely, there's no benefit. And they concluded that in extremely preterm infants with a large PDA, early treatment with the brufen is not associated with a lower risk of death or BPD. So, and then there is one trial, PDA tolerate trial, and there are follow-up studies of these. So I'm not going into that. Roughly, what to do, we don't know. So the only thing which actually, this is a position statement by Canadian Pediatric Society, but this came in 2022, before these studies were published. So really, I don't know whether we should follow or not, but this is a question, should early pharmacotherapy or conservative management should be used for management of a symptomatic ductus? And what did they recommend? May choose to conservatively manage a symptomatic ductus within the first 1 to 2 weeks. However, they will treat the babies less than 26 weeks. So 27, 28 weeks, even symptomatic, you can wait and watch unless the baby has features of severe cardiovascular failure. So people are moving towards conservative management and not aggressively managing ductus. So the final answer is not there. People will have different opinions, but again, that shows that we need a large study to answer that. Now, scenario 7, 27 weeks, 990 grams, the same baby. The 6th day of life, the baby is on assist control mode of ventilation, 30% FiO2, tidal volume of 4.5 ml per kg, PCV, done for some other reason, 36%. Assist control mode of ventilation, 6th day, PCV is 36%. What will you do? Will you transfuse packed or basis? Yes? No. Yes? How many? No? The remaining are, we will leave it to the consultant. Huh? Okay. So this is transfusion. So this is if I'm not wrong, this must be no. So here they randomized babies, basically extreme low birth weight babies, 400 to 910 grams, mean gestation of 26 weeks, liberal transfusion versus restrictive transfusion. They looked at death or disability at 24 months. There is no difference. Whether it is a restricted transfusion or liberal transfusion, there's no difference. And the same thing goes for the next, the top trial. Again, there's no difference between restrictive and liberal transfusion. So what do you mean by restrictive? So if you look at top and so easy to remember, in week 1, it's 33% PCV for babies who are on respiratory support or babies who are not stable. Week 2 is 30%, and week 3 is, so this is actually another thing. So grams per liter. So this is hemoglobin. So let us talk about hematocrit, because we usually talk in terms of hematocrit. So week 1, it's roughly 33, then 30 week 2, and week 3 and onwards it's about 25. So if you remember that, that's good. So based on this, so what they recommend is to use the restrictive guidelines, because there's no difference. So why to expose them to liberal, more blood transfusion? So the recommendation is to use the restrictive guidelines of E18NO or TOP. So this baby who's on day 6 had 36 PCV, I would not transfuse based on the existing evidence. Now, I think the last scenario, 27 weeks, 990 grams. The same baby, now 25 days, baby some CPAP, ROP screening shows zone 1, stage 2 with plus disease. What will you do? Review after 48 hours, laser, intravitreal anti-VEGF, option A, option B, option C. Okay. So this is a rainbow trial. There's a beta ROP came much earlier. So this is a rainbow trial which came in the last few years. This is ranibizumab versus laser. There will be 2 doses of ranibizumab and laser. The treatment success in babies with ROP, there's no difference, actually slightly better in anti-VEGF. And there is other trial, you can see butterfly and firefly and other trials. So based on this is the Royal College of Ophthalmology UK guidelines. How should ROP be treated? For zone 1 and posterior zone 2, this is evidence grade A, babies should be treated with intravitreal anti-VEGF. Okay? So for zone 2, there is not a posterior one, but for zone 2, you give laser. But for zone 1 ROP, you do, so anti-VEGF is the first line management. Now moving on to growth and development. I don't have a scenario. So this is a study which is published from India, the WING study. The impact of package of health, nutrition, psychosocial support, and wash interventions, that is water, sanitation, and hygiene interventions during preconception, pregnancy, and early childhood, a factorial trial. So what they did was, these are the things which they did. For nutrition, they provided iron and folate, multi-nutrient supplementation, egg yolk or milk if the mother's body mass index was less than 21. During pregnancy, they again did this, and then they give extra calories, provide one additional hot cooked meal. During early childhood, 0 to 6 months, lactation support was intensely promoted and intensely provided. 6 to 24 months, timely complementary feeding, and then they ensured that supplementary foods were given, which is 125 to 250 calories with different proteins. And they provide psychosocial support to the mothers. And they also made sure that wash and there's water, sanitation, and hygiene. So water filters, soap, hand washing station, disinfectants. For 0 to 6 months to 2 years, provide play mat and potty and so on and so forth. So they did a comprehensive, what they found was interesting. So this is stunting. The outcome is length for age, Z-score. Stunting, so if you look at A plus Z, there is a pink one, which is pregnancy plus early childhood versus the blue, which is the control group. There's a significant difference in the risk of stunting by 2 years if you intervene. A package of interventions, including psychosocial support, wash, and nutrition interventions, given throughout the pregnancy and even before pregnancy, will reduce the risk of stunting. And the relative score is 0.5, 50% reduction in stunting. Okay? So it's nothing we know, but this study showed what we know actually and what we can actually do. So there are other studies, many other recent advances. I'm not going into that. Studies, people are working on artificial placenta, artificial womb, physiologically based cord clamp. I have talked about that. Less invasive surfactant, newer ventilation modes, even though my core area is ventilation, but I'm just leaving that. Hot, physiology-based management of shock, then hypothermia, magenta trial, probiotics, renal replacement therapy, new, then so on and so forth, stem cells and so on and so forth. There's no, I cannot cover everything. So I will stop here, and I will stop with a quote by, which is attributed to Sidney Burwell, but we really don't know who actually made this comment. And those who read Doctor's novel, how many of you read Doctor's novel? Okay, so they'll know this. So this is a quote which is attributed to Sidney Burwell, who is the dean of Harvard Medical School. Half of what we have taught you is wrong. Unfortunately, we do not know which half. So that's with that I will end. Thank you.
Thank you, sir. It is really a honor and privilege to be chairing this session. My beloved teacher, Professor Jeeva Shankar. So in this half an hour, you have summarized the pioneering research studies, which has an impact on the practice of a neonatologist. Even though we may be kind of may not be implementing soon the results of most of the studies due to the practical issues which we face. My one question to you would be like how to address as a teacher, an academician, neonatologist in a leading institution. How do we address this gap between the knowledge which has come from high resource settings to implementing the same in LMIC countries? I mean, what can be the vision or maybe guidance for the young neonatologists?
Yeah, that's a good question. One, we should try to, first of all, we have to think, is there any physiological rationale why our babies are likely to be different than babies who are from a high income country? So if there are, in your setting, for example, simple example is IUGR. So if you have a double jeopardy, so you have prematurity as well as IUGR, that is not going to be the case in most high income countries, okay? Of course, they will see IUGR, but we had one baby who died 2 weeks ago, 29 weeks, 30 weeks, and 650 grams, which is very unlikely in a high income country, 30 weeks and 650 grams. So that's typically what many of us will face. So if you have a reason to suspect that these guidelines or these evidence cannot be extrapolated to our settings, then it's time for us to do a study. Don't do follow also, but I will not follow also. That type of intermediate khichdi type, don't do that. If you do, if you follow, then follow it properly. If you feel that there is a need, till that time you continue whatever we are doing, but try to answer that. Try to answer that by forming a network. There's no death of patients. You can have networks, you can collaborate, and there's no need for money for most of these outcomes. For death or BPD, for example, if you have to enroll 1,000 patients, death or BPD, you're just going to follow till the time of hospitalization. You don't need 2 years and need a follow-up, or you need a medical social workers, people to go to the homes and then follow. So most of these studies can be done without much funding, okay? So I would say that first, see whether there's any physiological rationale not to believe studies from high income countries. If there are none, then follow that. Follow the studies and then see, is there any difference? And then if there is a difference, then you find out why it is. If there is no, if you feel that there's a difference, the biological rationale itself is different, then don't use that, don't implement it as such, do a study, find out what actually the truth is, and then do that. Any other questions? Yeah.
The first question that you have raised, so I want the opinion from Professor Vishnubat sir. So why is that neonatal research from India is not making any impact all the world? So last time when we had the pediatric critical care conference, there are many Indian studies. The world follows the results of the Indian studies, mainly in septic shock and fluid therapy and all. Why there is no important neonatal research except for one, sir, probably the intubation for meconium, where the whole world follows if I'm not wrong. So why that neonatal research in India is not making an impact world over? I want your comments.
I think basically the research funding and the interest is very important. It's not neonatal research, the research in any field, because probably many times we are not very serious about research. That is the first issue. Second thing, probably whatever they say, we try to follow. So what you said initially, there is nothing new in many of the research work what we are doing. So if you want to make a landmark research, probably you should think what is new, what is innovation, how it can help. So if that is lacking, probably may not get recognized. Suppose somebody else has done, you repeat, you show same or similar result. It will not make any impact. That must be the reason. Because many times we follow the West, just let them do, then we will follow. So the idea should come from us. Probably it will help. Not that our studies are bad or anything, but many times the innovation probably is a little lacking. Want to add something?
Yeah, one thing is they are at least 30, 40 years ahead of us. They started in the 60s, we started in the 80s or 90s. So there was this thing itself, the starting point itself was different. And that's one of the reasons compared to many other specialties where they started at almost the same time, possibly. So that the point itself was different. Maybe down the line, we will not be talking.
I just have a comment to make. Even after I work in a private institution. Even after getting ethical clearance, parents get very suspicious when you try to get a signature on trials, And these days we get IT parents very suspicious. So these are practical problems. So how do you circumvent that, or how do you suggest?
I really don't have experience, I don't have experience in handling patients, private, so I really don't. But there's no shortcut as well, unfortunately. Informed consent has to be informed. If, for example, what I would do is, if there is one center which is digital, so I'll tell them that it's not only we are doing, but which is actually public funded, government funded one. Also, it's a multi-center that's also doing. So that is one way of thing. So that is not only doing conflict of interest. We do not have any conflict of interest. I think better to tell them up. This is not form funded, or it's not industry funded research. So if there is no conflict of interest, we have only thing is we're trying to find out what the truth is. So I think these two measures, and being this thing about it, that what are the potential benefits and the potential harms. So I think most parents might agree. But I do understand the consent is, if you even at AIMS, if you take EHS, only employee health, those who are availing employee health scheme, the consent rate is very, very low. Babies born to nurses, born to fellows and residents, babies born to faculty, the consent rate will be very low, unfortunately. So zinc versus placebo, many residents and faculty, they refused. You can't do anything about it, I suppose. Yeah.
Thank you, sir. Thank you, sir, for the engaging and thought-provoking discussions. We thank Dr. Chandrakumar, sir, for chairing the session. Request Dr. Chandrakumar, sir, to hand over a token of